I will introduce our first speaker, Dr. Juan Fortea. He is an internationally recognized behavioral neurologist and dementia expert. His major research interest is in the early diagnosis of neurodegenerative disorders and the natural history of Alzheimer's disease using a variety of biomarkers in the plasma, CSF, MRI, and PET. He joins us from the Hospital of Sant Pau in Barcelona, Spain, where he conducts a combination of his clinical and research activities. There, he leads the neuroimaging core, and he is also the founder and director of the Alzheimer's Down syndrome unit. This unit has the largest cohort of Down syndrome subjects followed longitudinally in a comprehensive manner globally. His work in this cohort of patients has made a very significant impact in the Alzheimer's disease field, documenting the natural progression of Alzheimer's disease in this cohort. Dr. Fortea also has been quite prolific with some 150 peer-reviewed publications, has a very extensive, successful grant portfolio, and he's also been very active in NIH study sections, has played a leading role in the Trisomy 21 Research Association, and is the current director of the Alzheimer's Association PIA on Down syndrome. So this afternoon, he'll be speaking about Down syndrome associated Alzheimer's disease. We very much look forward to hearing him.
So thank you very much, Thomas, for this very nice introduction. It is my pleasure to be here with you today. And hearing Thomas, I just regret not having added one or two slides about the impact of COVID on Down syndrome, and because it is huge and it is also disproportionate, and it's something that we are also looking into. In any case, what I'm going to talk today is about Down syndrome associated Alzheimer's disease. And I would like to start with a note on the epidemiology. And it might come as a surprise to some of you, but Down syndrome prevalence is not decreasing. It is increasing and increasing quite rapidly, as you can see here in this slide from a fairly recent epidemiological study here in the US. And this increase is mainly due to the longer life expectancy and the bigger proportion of older individuals with Down syndrome. Because as you can see in this first graph, what we've experienced in the last century is a dramatic increase in the life expectancy, as you can see here in this data from Australia, from people living less than 10 years at the beginning of the 20th century to over 60 nowadays. The problem with that is that some comorbidities that were latent, such as Alzheimer's disease, have emerged. And you can see here that recent longitudinal studies now estimate the risk for Alzheimer's disease in over 90%. Well over 90%, I'd say. And that is because it has a genetic origin. In chromosome 21, there are many genes, the most important of which is APP, or the amyloid precursor protein, which is both sufficient and necessary to induce Alzheimer's disease dementia. If any of you had 3 copies of this gene, you would develop presenile Alzheimer's dementia. And there are very few rare cases with Down syndrome who do not have this gene and do not develop Alzheimer's. So consistently since 2014, the International Working Group considers Down syndrome at the same level as autosomal dominant Alzheimer's disease. And it comes as no surprise from this data that AD is now the main medical problem and the main cause of death in adults with Down syndrome. To tackle this problem in Barcelona, between the Catalan Foundation for Down Syndrome and the Hospital of Sant Pau, we generated a health plan to screen for Down syndrome in this population. And we've been able to screen over 800 individuals in this health plan, and all of them are offered the participation in a intensive biomarker program that has enabled us to perform several multimodal biomarker studies. And here, as Thomas said, we were able in Barcelona to gather more participants than the whole of the DIAN International Consortia together. Just imagine how many people with Down syndrome you have in the New York area and how many subjects you could recruit for such studies. So how is DSAD? So first of all, DS is of course associated with intellectual disabilities, and this makes the diagnosis a bit more difficult. So if we find a subject and we ask him to draw a clock, he or she might draw this, and we might not know whether this is the basal function in an intellectual disability or AD, cognitive impairment. However, had we evaluated the subject for longer, and you don't need to be a neuropsychologist or neurologist to determine that this person is suffering from AD dementia. So bottom line is that we need longitudinal assessments, and sometimes we need adapted tests. For some subjects, a clock might be just too difficult. But if we do that, if we stratify by the level of intellectual disability, as you can see here, we have the age of the subjects, and in the y-axis, the Campo scores, which is kind of an ADASCORE or composite neuropsychological measure. You can see that those with moderate intellectual disability perform lower than those with mild intellectual disability along the whole lifespan, but we can track the decrease related to Alzheimer's disease. Or here you can see it in a different view. This is the different diagnostic performance, and you can see that if we stratify the subjects, we can measure and quantify this cognitive impairment due to AD, despite the noise, or if you will, that intellectual disability introduces. And we have a fairly good diagnostic performance for the neuropsychological tests. But if when we look at the progression along the AD continuum, we can confirm this ultra high risk people with Down syndrome have. And here you can have on the left panel people with a symptomatic Down syndrome, and in the right panel, those who have prodromal AD. And you can see that if we stratify by age, those that are older have a very, very high progression rate to prodromal AD on the left or to AD dementia in the right. And here you can see some figures that underlie this ultra high risk of progression. What about pathology? First of all, and this is well known from the 80s, from seminal work by Wisniewski, Dr. Wisniewski, that clearly showed that the AD pathology and the pathological hallmarks are exactly the same as in sporadic AD, the same topographic distribution within the brain and the same laminar distribution within the cortex. And this is true for amyloid, for vascular, and for tau. There might be more CAA in Down syndrome and in sporadic AD, but it's the same as in autosomal dominant. Another key aspect in both DSAD and the rest of the forms of Alzheimer's disease is, of course, inflammation, and this is truly present in also in Down syndrome. And Down syndrome was the first population in which we could detect the trafficking and alterations in the endosomes that were actually discovered in New York, first in Down syndrome, and then discovered in the euploid population. But we can learn a lot from Down syndrome. So in this slide, what I want to convey is that the AD pathology is a lifelong process. And as you can see, it starts in the teens with Down syndrome in the forms of intraneuronal amyloid. Then it evolves to extracellular diffuse plaques, and then both neuritic and plaques and neurofibrillary tangles, and eventually they develop in a full-blown dementia, full-blown neuropathology, sorry. And as you can see here, biomarkers can track some of these changes, but later and with a certain temporality. And for instance, PET tracers can detect this pathology about 10 years later than CSF biomarkers, for instance. And this is true in sporadic AD, and also, as you can see in the right panel from this paper from McDade and Bateman, also in autosomal dominant Alzheimer's disease. But Down syndrome has here an advantage, because we can also study these earlier phenomena that we cannot study neither with sporadic AD nor with autosomal dominant. And that is because we simply do not have enough specimens of autosomal dominant Alzheimer's disease mutation carriers that die in their teens or 20s. So if you want to capture this lifelong process, DSAD is a fantastic model to do this. What about biochemical biomarkers? So let me emphasize again that if we have a similar AD pathology, it comes as no surprise that we have the same biochemical signature for the CSF biomarker findings, with 50% decreases in the amyloid levels and twofold increases in phospho-tau levels. And this is important because these biomarker changes allow us to have a very good diagnostic performance of these biomarkers. And as I said, it can be a difficult clinical diagnosis. So this was in itself a very important result. CSF biomarkers can help us a lot. But what the game changer in this study we published a few years ago was that plasma NFL levels were equally in green here, were equally useful in diagnosing symptomatic AD. And this is a game changer. This means that with a plasma test that costs about $50, we can really diagnose with good certainty symptomatic AD in this population. We have now follow up on this study, and we've led this international study with these several centers in Europe and in the US, trying to confirm in this multi-center study the diagnostic performance, but also assess the prognostic and the performance of these levels and the longitudinal trajectory. And I'll focus on these last two objectives. So first of all, in this paper that has just been accepted in Lancet Neurology, we could show that those that had high NFL levels in blue progress much more rapidly to symptomatic AD than those with the median turtle in green or with low NFL levels in red. And importantly, we could show also that the longitudinal trajectory in the symptomatic stages was good, meaning that we still saw some increases in these symptomatic stages. And this is important if you want to use NFL, plasma NFL, as a theragnostic marker in clinical trials. So it has they do not plateau as phospho-tau in CSF does, for instance, and this excellent behavior will allow its use, we believe, in clinical trials. So we've also collaborated with Henrik Zetterberg and Kaj Lennon in Sweden in this paper that was just accepted last week in Nature Communication. And we could show that plasma phospho-tau levels have very nice increases along the AD continuum. So the left panels are plasma phospho-tau, the right panel plasma NFL. And you can see that the behavior is exactly or very much alike, which comes as no surprise because most of the neurodegeneration in this population is due to AD. So phospho-tau is tracking the neurofibrillary tangles and plasma NFL, the neurodegeneration. And here we could see that plasma phospho-tau levels also correlate very nicely with the atrophy pattern and the hypometabolism in the brain. And this is mainly driven from symptomatic participants. We've assessed in collaboration with Paul Worley and John Hopkins the CSF pentraxin levels, which are very promising synaptic biomarker, and we could see that there is a decrease, as it had been described in sporadic AD in Down syndrome, and also correlating with cortical thickness and more importantly even with FDG PET uptake. We, Olivia Belvin and Alberto Geo in our group have a panel of synaptic biomarkers that have been patented. And here we saw that BAMP2 is a very promising synaptic biomarker that could be a surrogate marker of episodic memory. What about imaging biomarkers? So let me first give the most important message. It is exactly the same as in sporadic AD. So we have the same atrophy pattern, the same hypometabolism, and the same amyloid deposition. And whenever we find some difference, such as a very early striatal uptake in the amyloid PET, it is because it has been described in autosomal dominant Alzheimer's disease. So easy message, it has the same imaging signature as in sporadic AD. This doesn't mean that we can find some differences in some biomarkers, and this is exemplified in this study we performed with a magnetic resonance spectroscopy. And here we could see that, for instance, myoinositol here is increased in asymptomatic individuals here in yellow with respect to auploid controls. And this is further increasing symptomatic stages. And this is probably due because we have a transporter of the myoinositol that is coded in chromosome 21. So this is kind of a neurodevelopmental difference that we are seeing in asymptomatic individuals. But then we have the same increase in symptomatic AD as it has been described in the general population. And acetyl aspartate has the same behavior with a decreases in symptomatic stages as that described in sporadic AD. So we're also looking to the cortical microinfarcts. We believe it's a fantastic model, as we can see, as we will see, to study the natural history of these microinfarcts that are probably related to CAA and that might be very important in cognitive decline in Alzheimer's disease in general. We've assessed also the different imaging characteristic of CAA in this population. And as I said before, this greater CAA burden that we can see in pathology in autosomal dominant and Down syndrome has a correlate in the MRI findings. And we do see more modified Boston criteria or subjects fulfilling this criteria in these two genetically determined forms than in sporadic AD. But the biggest opportunity, as Dr. Brzezinski was saying, is that it is a fantastic model, Down syndrome, I mean, to study the natural history of the biomarker changes. And this is exactly the objective that we wanted to do in this paper that was published last year in collaboration with the group of Sahid Saman in Cambridge. So here, I will not go into the detail of every panel, but just to illustrate that the x-axis is always the age and the y-axis is the biomarker levels of different biochemical and neuroimaging biomarkers. In red, we see the trajectories for people with Down syndrome, in blue for euploid controls. And as you can see, there are very early changes and a very predictable sequence of events in which CSF beta values change first in the late 20s, followed by plasma NFL elevations. Amyloid PET interestingly, takes about 10 years to be significantly high in this population. FDG and CSF phospho-tau occur in the mid-30s or late 30s, whereas hippocampal atrophy and cognitive changes do not change into the well into the 40s. Prodromal AD is diagnosed at a mean age of 50 and dementia 3 years later. And here, what we did is to use the same statistical model in the left, in the Down syndrome as DSAD, and that as Randy Bateman did in his landmark paper in 2012 in New England Journal of Medicine. And as you can see, when we use the same methodological approach, we could see that the trajectory is strikingly similar. This predictable sequence of events in Down syndrome Alzheimer's disease is exactly the same as that described in autosomal dominant Alzheimer's disease. And so we can test a lot of modifiers to assess the impact on the AD natural history, the most important of which is, of course, ApoE, for instance. And here we could, in this paper that has just been accepted, we could see that the ApoE has a 2-year impact on the clinical diagnosis. And this is 2 ways to show the same result. But also we could assess what pathophysiological mechanism or by which mechanism ApoE was exerting this effect on the clinical symptomatology. And we could clearly see an impact on CSF A beta levels or amyloid uptake, with earlier amyloid uptake in ApoE4 carriers, and slight but significant changes in phospho-tau and in FDG. And this is well in agreement to the changes that have been associated with ApoE in the general population. We could also assess a very trendy topic, which is the sex differences. And here I show the main effects, and the main effects are negative. Sex does not seem to modify the diagnosis of dementia or the trajectories of the main biomarkers. We do see some interactions with ApoE that we can dive in the discussion, but the main effects are mainly negative. So there are new times for Alzheimer's disease, or DSAD, I would say. So first of all, this opportunity is being increasingly recognized. So you can imagine whatever biomarker you're studying, whatever trial you want to assess, and if you want to really assess when in the disease process it is changing, it is a fantastic model in which to assess it. And this is why we are now collaborating with several companies and researchers around the world to assess, for instance, tau PET or the new plasma A-beta assays or the alpha-synuclein with RT-QuICs techniques. And we will try to assess when in the disease process these biomarkers start to change. But the most important opportunity is, of course, in trials, because it is probably the only population in which you can design the trial of your dreams. You can decide what in the ATN, and it's important that you decide whether you are going to define the ATN with CSF or PET biomarkers, which are not the same, but you can decide when what biomarker combinations you want to have, whether you want to have a primary prevention, a secondary prevention, or symptomatic trial, take into account the clinical symptomatology and the FDA guidance. And you really, if you have a drug, it is a fantastic population to really select with sufficient numbers the timing of your intervention. And this, with autosomal dominant AD, you can in theory do that. But as I said, we have more subjects in Barcelona than the Diane study. And in New York, you have far greater numbers, orders of magnitude higher. So you can really intervene in this population. And what we are lacking is that the advancement of this field cannot be the effort of individual groups. We have to have consortia, and this is happening. There are several consortia in the US and in Europe that we are joining efforts to try to really have trial-ready cohorts in which we can really understand better the natural history of AD in this population and accelerate the participation in clinical trials, which are ultimately our objective. So, because as I said, DSAD is all about amyloid and tau, of course, because we have this gene dose effect in the APP gene that eventually leads to a cascade of events leading to clinical AD. It is clear we can take amyloid out of the brain, whether this changes AD in the general population or not, that remains to be proven. But certainly we must test these therapies, I believe, in Down syndrome. And they are actually about to start in this trial that probably will start with active vaccination later this year. And I'd like to mention that not performing research in Down syndrome is a subtle but new form of discrimination. They are willing and ready to participate in research studies. And I will end up by saying that we do believe that DSAD can be considered that as within this virtuous cycle between sporadic AD, autosomal dominant Alzheimer's disease, and Down syndrome Alzheimer's disease. And really, we can learn from each other and advance our knowledge of Alzheimer's disease. And just to put you two examples, and just because of the talks that you will hear now, is that DSAD is a stress model for many things. So you know that AD is related to epilepsy. Well, it is even more so in Down syndrome. Over 50% of those with dementia develop a specific type of epilepsy that is called late onset myoclonic epilepsy in Down syndrome. And this is the algorithm that we've developed in our center. So if you want to study this relationship, you have more epilepsy than even in autosomal dominant Alzheimer's disease. And the other example, for instance, and this links to Ricardo's talk, is that if you want to study sleep and obstructive sleep apnea in this population, it is also a stress model. So here you have healthy controls. You can see that Down syndrome, even asymptomatic individuals, do have many more sleep apneas, and we can discuss why this is so. But they, with prodromal AD or AD dementia, we still have more sleep apneas. And of course, we have more amyloid because we have this extra copy of APP. So if you want to assess the clearance mechanism and this interaction between production and clearance, you have this really a stress model to investigate. And with that, I will end up by concluding that Down syndrome is a form of genetically determined Alzheimer's disease and a great model in which to study the disease, that preventing trials against AD are feasible due to recent advancements in AD pathophysiology and biomarker research, and that the international networks and trial-ready cohorts are being built to perform more observational study and clinical trials. Let me finalize with this statement that I do believe AD might be easier to cure in Down syndrome than sporadic AD. It is much more homogeneous, and it's certainly the best population in which to perform prevention studies, because you can choose the timing of your intervention with sufficient numbers or subjects. And with that, I would like to thank the participants and our colleagues in the Down syndrome unit and the memory unit, and of course, the funders. Thank you very much.
Thank you for a fabulous talk. And perhaps we have time for just one or two questions. Of the potential clinical trials that you envisage in Down syndrome, what would be your #1 pick approach?
I think that any good approach that you can think of in sporadic AD, you can test it in Alzheimer's, in DSAD. However, I do believe that it is clear that the amyloid cascade hypothesis has its biggest evidence in autosomal dominant and Down syndrome. So as I said, it's clear that APP dosage is both necessary and sufficient to produce AD. And we have the Icelandic mutation showing that if we reduce A beta processing, we have reduced dementia. So to me, it's very obvious that a prevention trial with anti-amyloid therapies must be tested. And even if the symptomatic trials in sporadic AD fail, I think it would be a mistake not to try these therapies in DSAD.
Thank you. There's a question actually in the Q&A box, but Mitchell, I unmuted you if you want to.
Yeah. Hey, Dr. Fortea, how are you?
Hi.
So my question is, there is also currently a focus on the biomarkers for the endolysosomal pathway, for instance, now that that is really important, I mean, for both AD and evidently for Down syndrome, and maybe to focus the studies also on that part as well, if that could define probably if AD advances faster in Down syndrome, or if there is a relationship, or I mean, yeah, something like that.
Yeah, absolutely. So I went very quickly, but that was discovered in New York, at NYU, actually, in these endosomal trafficking problems, and it was discovered in Down syndrome. And then we discovered that it was important in sporadic AD. And not a lot of people know that the A-beta protein was discovered because it was isolated from CAA of Down syndrome brains. So we've learned a lot about Down syndrome, about Alzheimer's in Down syndrome, and I think now it can be the case. But I fully agree. We thought that there were enlarged endosomes. Now, Marie-Claude Poitier in Paris has shown with ultrastructural studies that actually it's cluster endosomes that in light microscopy seem like enlarged, but certainly they are clustered, pointing again to these trafficking problems. And you could even think that A-beta amyloid can impact this trafficking within the cell. And it's even more, maybe this is more important than the extracellular amyloid plaques. But certainly these intracellular trafficking problems, which were discovered in Down syndrome and Alzheimer's disease, are probably very, very important in the disease process, are gaining momentum, and there is really nice work by Ana Maria Cuervo at Einstein University in northern Manhattan that point to that. So I think it's a very, very important question.
Right. Well, thank you very much for a fabulous talk. There'll be time for more questions at the end of this session. So we'll move on to Dr. Helen Scharfman.